Hello, and welcome back to another episode of More Than Milestones. I am so excited today to be joined by Lo, who, if you don't know her, she is a mama of four, a wife, an RN, and certified lactation consultant with specialty certifications in obstetrics. She has spent her nursing career in labor and postpartum nursing and built an online education platform to get families the information they actually need for how it really goes in both birth and the months at home to follow. So today, we're going to be digging into an honest breakdown on all things labor and delivery. So thank you so much for being here, Lo. I'm so excited to chat with you.
Yeah, thanks for having me. I think it's fun to be on the other side of the mic. I feel like you might have said that to me as well when you chatted with me, but sometimes it's nice to just answer questions and not have to think of the things and just talk about what you love. You know what I mean?
Totally.
Yeah.
I love it. I'm so excited. And I feel like this is a really great conversation because there are so many things that no matter how much you prepare for, you just can't prepare for when it comes to labor and delivery. So I'm hoping that we can kind of unpack some pregnancy stuff, some labor and delivery stuff, some after delivery stuff. All right, let's get right into it. So let's start with pregnancy. Just in general, like large overarching umbrella conversation. In early pregnancy, what can someone really expect with testing for an uncomplicated pregnancy versus, say, a high-risk pregnancy? And I would also love if you can kind of just explain, like, what is a high-risk pregnancy? I know there's all different reasons, but, like, break that down for us.
Ooh, the question of risk, I think, is complicated because there's like so many things that could like infer or then mean there's this inherent risk. And there's also not like very clear guidelines on when exactly you step over from, depending on what we're talking about, from like low risk into high risk. And this can get complicated too in labor because a lot of times you'll hear education from someone like myself included where I say, hey, if you're low risk and nothing's going on and all things are quote unquote normal, like it's totally appropriate to ask for XYZ or to have this choice or whatever. And then as soon as the risk changes, then something may not become appropriate or you need to have a new conversation with your provider. Let's see, something like, having an IV or declining third stage Pitocin. Like you always have the right to decline things, but risk should be a really smart, healthy part of that conversation because then you can say, this is my risk of XYZ, and it then changes maybe like what research indicates for me or what outcomes could be indicated, et cetera. And so I think I think the idea of risk, sometimes it's established right from the start, right? Like, let's say baby has an existing condition that we know in utero. Okay, then that baby is high risk, or that pregnancy then has become high risk, right? Or maybe you have preeclampsia and we're sure of it and, your blood pressures are through the roof and you have protein in your urine and all this stuff. Okay, you are now high risk. So sometimes it's really clear. I think it's really good for us to understand that through pregnancy and then through labor as well, our risk can change. And that's not something to be fearful of. It's just something to go, okay, as I make choices, like recognize that this is a changing thing. And so I could be low risk today. And in theory, something could change tomorrow. And that just means I need to reassess, whatever choice I'm making or whatever options I have. And so when it comes to risk in general, like to answer that question of what is high risk, it's in general, like anything that takes you outside of the confines of normal in all these different categories, right? So some people could say certain weight puts you in a higher risk category. Blood sugars put you in a higher risk category, right? So that's where we do that GDM screening. GBS status doesn't necessarily put you in a high-risk status, but if you're GBS positive, which is one of these screens that we do, and I know you asked about tests and screens and things in pregnancy, like that puts you in a different sort of category for making choices. Blood pressure changes puts you in a different category. This list could go on and on and on, but I would say blood sugars, so that's why we do that gestational diabetes screen during pregnancy, so that's one that everyone can expect to come up. And then preeclampsia, which is high blood pressure and kind of any of the high blood pressure conditions that could get us to there, like just having gestational hypertension. I know I'm throwing out a lot of like diagnosis words. But those two we're kind of paying attention to throughout pregnancy. The blood sugar one, checking on blood pressures, particularly at the end of pregnancy. So those are common things that can change toward the end of pregnancy. And so they're being looked at a lot. In terms of tests and screening, I think you could clarify for me what you're speaking about specifically. But, we have a lot in the first trimester that's kind of establishing health of baby, right? And a lot of this is going to be genetic stuff. And so like at your 8-week, 10-week, let's say 12-week appointment, we have blood draws, ultrasounds, different screens. And I do like to say all of this is always voluntary. So it is a choice of would you want to know this information and would you not? And then, of course, some people would say, then what are you going to do with information? So that's
Mm.
like another part of that. And so those are a lot of the screens. Like I'm going to throw out some acronyms here, like the NIPT test, the NIPT one. And that's a lot of people like doing that one because you can learn sex of baby really early. But
Mm.
it's also looking at, like different genetic conditions that could be present in baby, some of the trisomies, things like that. You have the nuchal translucency screen, which is an ultrasound where they're looking at baby. That's usually around like 12-ish weeks. Some people do that, some people don't. There's a quad screen, triple screen. There's kind of all these different ones.
Mm.
Um, a lot of people their insurance allows for or doesn't allow for certain ones in terms of would you have to pay or not. That can be dependent on your age, established risk for your pregnancy, different things. So that the early trimester, there are, I would say up to like 16 weeks, a lot of screens potentially available to you. Most of them are going to be like via a blood draw or something like that.
Mm.
And then should something come up in that, then we run into things that could actually be diagnostic. Like if there were an issue or an area that we wanted to say, hey, we got to look a little closer at what's going on here if you want to, then you get into actually diagnosing if there's something going on with baby. And then I already mentioned these two, but you have your gestational diabetes screen, usually around like 26, 28 weeks. That's for you. Might be earlier if you have some risk for GDM, but if not, it's usually at that point. The GBS screen is around 36 weeks. I think that's most of the standard. Your 20-week ultrasound,
Yeah.
everyone knows about that one. Yeah.
Amazing. Okay. That is super helpful. And
Yeah.
I want to circle back to the changing risk and understanding that when we talk a little bit more about labor and delivery, because I think that's a really important part of advocating for yourself, but also understanding that like the trust with your care team and that communication really has to be there because things can change really quickly. But we'll circle back to that. So for the next part about pregnancy, I really want to hear your thoughts on hospital versus home birth versus other birthing centers. Where do you feel it's most beneficial for people to start in terms of making decisions on where you want your labor and delivery to ideally or potentially be?
I just watched a TV episode the other night, and the doctor on the episode said, I loved it. He said, I think the best place for someone to have a baby is where they feel the most safe. And he was actually a doctor who was supporting home birth, which was coming in like the character was shocked that this doctor was saying that to them because
Mm.
sometimes that might not be the narrative from some MDs or OBs. But I really do agree with that. And I think that it's a good thing to think about when you are pregnant, when you're thinking about it, is this idea of like, where do I feel safe and what makes me feel safe? And the reason I think that's important is because a lot of times, sometimes you get this idea that hospitals like are unsafe, right? And we know there's lots of interventions there and they can lead to certain outcomes. Like I'm not denying that at all. But some people do feel safe there, or the provider that they love and that maybe has been with them their whole life delivers at the hospital. And so that's something that makes them feel safe, right? And so I think regardless of whether we're talking about birth center, home, or hospital, this idea of what makes you safe, who makes you feel safe is really important to think about. And then recognizing that that might be different for you, or it might be deeply personal, that your emotions might come into play, and that it might not be just about like what the research says or what your sister's telling you or what your favorite social media influencer is telling you about where the best place is to have a baby. I just think the safety and what makes us feel safe is really personal and really unique. And so that is a big part of where we should start. And then practically speaking, I teach a lot about this idea of understanding, like, let's say if you're going to hospital, there are providers who can deliver at certain hospitals. So if you're like dead set on a certain hospital because they have the highest level NICU or you just love it or they just renovated or whatever, then you have to figure out which providers deliver there, like if that were a priority. Alternatively, if you have a provider you love, you might find out like, oh, they don't have privileges at a certain hospital or they only deliver at one hospital. And so this idea of specifically choosing a hospital is really kind of intertwined with the provider and where they're allowed to deliver, or where they have relationships with too. So just knowing that you might not always be able to pick this provider and this hospital, and that those two actually can go together.
Mm. What is the actual difference between a birthing center versus a hospital?
So birth centers can be freestanding, so unconnected to a hospital, like down the road or 5 minutes away. There are rules, or I should say, like legislation everywhere, and it can be different state to state that says like how close a birth center has to be to a hospital, like should an
Mm.
emergency or a need for transfer arise. So they're not always the same. That rule is not always the same everywhere. And then you can also have birth centers that are like attached to hospitals sometimes, which is cool. So it's on the hospital grounds, but you are still totally removed from, we'll say, like maybe a more an intervention forward. Like you don't have the epidural available to you. There's no
Oh,
ORs like
wow.
on the unit or downstairs. You're kind of separate from that one. And then in general, for either of those, whether you're connected or not, you're definitely looking at a more, I'm going to use the word like holistic process. Like there's no epidural anesthesia available to you. Obviously, there's no surgery available to you like immediately. They can still do IVs and they can still do lots of, people ask about like fetal, like NR, neonatal resuscitation. NRP is a certification, like helping baby after birth if they need that. These midwives still have lots of those skills to do most of those things. It's typically just a few scenarios where it's like, we can no longer care for you at a birth center. But you are making the choice to deliver unmedicated if you're at a birth center. You can have IV payments, things like that, but you don't have that epidural available to you.
Very interesting. I didn't realize that about the epidural. It's funny because not funny, but I felt when I made the decision. So I actually went backwards the way that you were saying. I wanted to be sure because primarily of my background and what I do and taking medical histories and hearing things that maybe didn't go as planned. I wanted to make sure that we were at the highest level NICU. So I chose the hospital first that was like the closest to Jay coming from New York City to me, and then had that higher level of care. And I then found an OB and it ended up being incredible. But I definitely felt like I was judged a little bit for that. Like people were like, oh, you're setting yourself up for something bad to happen. And I was like, no, I just want to make sure that if God forbid something does, and it did. So thank God we were there. But yeah, it's interesting, like the judgment that gets wrapped up in the whole conversation, like kind of from start to finish. Like every decision you make feels like someone's, I don't know. Anyway.
It's a perfect example of that idea of what makes you feel safe, though.
Yeah,
Like
yeah.
have things in your brain and in your history and from your job that you feel safer being in a certain place, right? So, yeah, maybe a lot of parents wouldn't choose based on NICU, but you did for really specific reasons
Yeah,
because it made you feel safer. I just think that's why we should really start there and then recognize like someone else is not going to agree with me because the way they feel safe is not the same as the way I feel safe. Like
totally.
we're all too different for that.
Totally. Can you break down the difference for us between a midwife versus a doula versus an OB, just for anyone that might not really understand the intricacies of that?
Yeah, I love this conversation. When I was pregnant with my first baby, I told my mom I was going to have a midwife. And she did kind of the classic, like, is that safe? Are you sure? And it was just so cute. I still remember being like, Mom, yes, you don't know what a midwife is. Because she's probably picturing like a lay midwife from movies way back when, like delivering out in the field,
Yeah.
more pre-birthy. I don't know.
Yeah.
I feel like she really still had that. And I'd been working at the bedside for years. And so it was very clear to me, like midwives can do basically like almost everything. Typically they don't have surgical privileges, but some of them can get certified to assist in surgery. So they're not the
Oh,
primary surgeon in the C-section, but most of the midwives that we worked with were like the assisting surgeon. And so they were in that OR if their patient became a cesarean. There's different types of midwives, and that's valuable to know as you're looking for one, regardless of where you're delivering and where you're interacting with them. So there's certified nurse midwives, certified professional midwives, direct entry midwives. There's these different layers. And it just is an indication of how much education they have, where they got that education. Typically, a CNM, that first one I said, is going to often work in a hospital setting. Certified professional midwives and CNMs both might be working at birth centers. Sometimes it's more like a CPM, or the direct entry midwives that might more be at doing home births. That is very general, you guys. So if you're looking at midwives Or if you are a midwife, you might say, that's not true of me. But they do have some different certifications and qualifications. So if that's important to you, or as you're interviewing midwives or figuring that out, yeah, it might be something you want to ask them or look into as well. At a hospital, I think it's nice to know a lot of CNMs typically, they work really closely with OBs, and those are your obstetrician gynecologists, right? So they've gone to school specifically for OB and specialty certified and board certified, a lot of them, not all of them. They can do surgeries. They're usually doing GYN surgeries. They do your C-section. They can handle the highest risk and acuity for pregnancy and labor complications. An OB is someone that if a CNM needed help, they often work, I'm going to say, like under them or in partnership with them. So should something get outside of a CNM or a midwife's scope, then they're calling the OB, right? Or they're saying, hey, take a peek at this chart. Or they're saying, hey, I need your help with a really, maybe significant repair in the OR. There are times where that OB needs to step in and help and support. But in general, those midwives can do most nearly like everything for you. And then in theory, you could risk out of their care, or they need even more collaboration with the OB, that OBGYN, and they step in. We had a cool partnership where I was working, where you just got to see the full autonomy of a midwife. I mean, they worked with OBs, and there was like 5 or 6 midwives with this OB practice as well. But the midwives just did everything on their own. And every once in a while, or for a C-section, the OB was involved. But you got to see just how much they did. I mean, from start to finish, they handled the whole thing, all the pregnancy. And then doula is support person. I know you asked about them as well. So they are clinically not doing like cervical checks, or obviously they're not charting, they're not a hospital employee. They're there as decision maker supporters, not shouldn't make decisions for you, like helping you advocate, incredible educators. And I would say really typically so good at just an awareness of the physiology of birth, how to decide how to move and move through birth, and like options and choices for you. Really incredible. They should be at incorporating your partner as much or as little as they're comfortable with. I just picture them as like the ultimate birth squad team member, but they're unencumbered by having to like chart and make like clinical decisions. They can just wholly be a human being, all in for you, not underneath any protocols or rules, like maybe even the nurse, the midwife, the OBR. Just a lot of freedom.
I love that.
Yeah.
I love that. What would you say is the draw for, or in your experience, what is the, I don't want to say benefit because that's not the right word, but almost like what would lead you to wanting a midwife over an OB?
I think in general that typically midwife, there's something called a midwifery model of care. Like you can Google this and look it up. And it is different than what you're going to see in the normal kind of obstetric prenatal care and labor care world. It's typically leaning more towards this idea of like wholer body, whole person, having time for that. So a lot of people might hear, oh, my first midwife appointment, and this is going to be more true of like a home birth midwife, still not a hospital-based midwife, but you might have like a 90-minute appointment, right? And they're asking you about your kids and your family and your emotional health. I mean, they're really leaning in to all of the facets of you, not just like, hey, how's your pregnancy going?
Yeah.
And then this follows through in birth as well. And I think often it leads to like unmedicated birth, lower intervention birth, more of just leaning away from jumping to intervention and first saying like, what are other options for us? What are other things that are available to us? Just slower to intervene, often more of a patience, I feel like, with really even the challenges of pregnancy, and then also labor as well, where it's just like a little bit more of it, this is normal. We have time. We can hold space for this. I know those are sometimes kind of like woo-woo words, and not every midwife's going to be like that. And there's a lot of OBs who are incredible and really do lean that way in their practice now. But in general, there is a midwifery model of care, and it is different than what we're typically going to find with an OB. OBs often are really limited by time. I mean, that's just a
Yeah.
practical thing. They're in the clinic, they're running over to the unit to deliver because like during daytime hours and they got to go back to patients. I'm sure some of you have had an appointment, get bumped because the OB's like truly in the middle of a C-section.
Mm.
Midwives often are more of a team, particularly hospital-based midwives. So one of them will be in the clinic and the other one's on the floor staying with the laboring patients. So you often just get more hands-on care and they're more available to you should you
Mm.
want them available to you.
Interesting. Are midwives covered by insurance typically? The same way
Yes,
an
but
OB would be?
I
Oh.
I'm not even gonna suppose I don't know if they're like under their practice, like if they're
Yeah,
part of
yeah.
an OB practice, if they carry their own,
Oh,
probably
I see.
looks really
Okay.
different based on where they're delivered. Like, are they home birth midwife? Do they work at a birth center? Because
Gotcha.
these practices have insurance.
Gotcha.
Like the midwives that I'm talking about, a lot of CNMs who work with an OB practice, or my guess is it's part of that umbrella. But I have no
Yeah.
idea.
Yeah, yeah.
Don't quote me on any of that.
Yeah, yeah, yeah. That's really interesting. Really interesting. Okay, so let's speaking of working with your support team and your partner to really like determine what your hopes and wishes are for labor and delivery, let's like pivot into labor and delivery. I would love to hear you talk about the cascade of interventions from your point of view. And I think for me, I was induced all 3 times because of gestational hypertension, one of which almost turned into preeclampsia. And I felt anytime I hear people talk about the cascade of interventions and, oh, well, if you do this, then XYZ is going to happen, it was hard to not feel like there were things that were out of my control, even though I'm not saying that I didn't feel respected in my wishes, but it definitely felt like things did kind of like cascade a little bit each time. And one of them it escalated. And I think it's a common phrase that people hear, but can you break down what that really means from your point of view?
So the cascade of interventions is this idea that kind of once we make a choice and start a process in the hospital, often like induction is a perfect example, whether we're choosing induction or it's necessary, honestly, for a medical reason as well, that it then kind of opens the door and we get this like tumble down effect. So like, let me play this out for a minute. Pretend you need to be induced, and let's say it's medical, so you're not feeling like I chose it and then caused all these things. A medical induction is needed, right? And you're 39 and a half weeks. So we go in and right away, intervention number 1 is starting this induction, right? And so we're introducing some sort of medication to ripen your cervix or whatever, depending on where you're at, right? And then it's a good chance you might need another medication 6 hours later, because often this takes time, right? And we're going slow. And then at some point, they might want to break your bag of water, right? Or they want to do something else to keep things going, because we're really kind of helping this ball roll down the hill, particularly induction, because sometimes we're really starting the process from zero, right? And then for many people, the pain of induction and the length of induction, because they can be long, they can be slow. It's exhausting. You're tired. You've been dealing with contractions for, 26 hours at that point or whatever. And maybe you're 5 centimeters, you're 6, and things are really just getting rolling. So then you're choosing an epidural, maybe sooner than you would have, maybe because maybe you didn't want one at all. There's lots of reasons, right? And so then you have an epidural in place. And then maybe the epidural slows labor down a little bit. So we've got to introduce the Pitocin. And then maybe we need an IUPC because we can't figure, that's an internal monitor that tells us how strong contractions are. So maybe we need to utilize that because the water's been broken for a while and the Pitocin contractions don't seem strong enough. And so then we have that going on as well. And so you can just see how it's like not necessarily A will lead to B will lead to C, but there is this potential when we kind of start to introduce certain things that this chain just starts happening and it just, the ball just starts rolling down the hill. And while, like you said, you can be active inside of those things. You can say, I know what an IUPC is. Like, I remember learning about this. I know the risks and benefits of breaking my bag of water. They talk to me. Like, those can all be good conversations. But there's still this idea of what you said of all of this stuff was just happening. It can go great, but still, you can still be inside of that chain.
Yeah, yeah, totally. So how do you recommend, I want to talk more about pain management in a minute, but how do you recommend really like what to expect in understanding and making decisions around things like induction or just in general with your labor and delivery, and not even considering like knowing that things will change, but maybe even just like in the development of like, these are important things that you should be thinking about that could be happening to you during labor and delivery. Like where do you want to give birth, for one? Do you want to have a midwife? Like, once you actually get into the labor and delivery, what are some of the biggest things that you feel are important for people to understand that they might have to make decisions about?
One of my favorite things to have people do, or there's this worksheet in my courses for students, is prioritize the things that really matter to you for your birth. And I like that language of birth priorities. This is separate. I have a birth plan too, right? But it's a like little priorities worksheet where you can actually go through and think about, this is kind of specific for labor, but what it is that you most want to happen, right? Ultimate outcomes, other outcomes, and as big as like, or specific as, I want a vaginal birth versus cesarean birth, but then, I want less monitoring, or I want to be able to move around. And there's like 12 or 14 things on it. And I like having people prioritize because I think it kind of shows you that as you pivot, or as plans change, or as you decide that an induction is the right choice for you, you can still, like, maybe that's on the list, right? And maybe that's something that in theory you didn't want to do, or a choice you didn't want to make, but you can still look at your priorities and see the things that you can continue to work for. I don't want to say fight for, but like continue to have goals. And so as we're making choices at the end of pregnancy for, maybe induction, but then even in labor as well, I like this idea of, hey, if I don't like the vocabulary concede, but that's what popped in my head. But like, let's say that's what it is. If I go ahead and choose to do Pitocin, what are the things that I, still have going on? What are these goals that I still have in front of me that can still be something that I'm working towards and still be something that I'm making decisions towards? So then you're making pro-con choices with that in mind, whatever those existing higher priorities are. Because I think a lot of people, as we go through birth, you are going to ebb and flow, right? And you're going to say, oh, I really cared about all this stuff. And then I ended up like, I didn't care about that because it meant I could still have this. And so I think being able to walk into choices, knowing, obviously, like all of us know, learn the pros and cons, the alternatives. And you can always, ask for time and space and, those brain tools that so many of us talk about. But then this idea of these priorities and which ones you can still continue to work towards and hope for and be moving towards, even as you find that there maybe are some other places that you are choosing to pivot or need to pivot.
Yeah.
I think sometimes we just get so hung up on this one thing. And if we lose that, it feels like all of it has fallen apart. So I love just encouraging people to see the little wins and the continued ways they can continue to capture or get to some of the different things that they're wanting.
Yeah, I love that advice. And it's funny, with Austin's labor and delivery, my youngest, I went into it like real cocky, like really cocky, because my second, it was like the most healing, easy labor and delivery. And I was like, oh my God, I like got the epidural. And then like she was born later, like 15 minutes later. And I was like, oh, I could totally have made it, blah, blah, blah. I went into his birth so cocky. And it was literally like one thing after another. Like I really was like, I want to labor in the tub. The tub wasn't available. Then it was like, I really wanted my sister to be there, but she wasn't a doula. And I had talked to one person at the hospital that was like, she can still come. It's okay. Because this was like just the tail end of it. Yeah. So like Jay was allowed to be there, but they were kind of iffy on the second person. And then she wasn't allowed to come in. She had driven all the way from Brooklyn and was like standing outside the hospital and they wouldn't let her come in. And it was like, that was the second thing. And then I don't even remember the third thing, but I was like, that's it. I'm done. I just get this kid out of me. Like, I don't even know what to do right now. So I love the idea of like having tiers almost of like, okay, if this doesn't go my way, there are still things that I can be in control of, really,
It's a tough thing because it's not like that stuff didn't matter, like it's not like having your sister there wasn't incredibly important, and it really, really sucks that she didn't get to be there. So I think it's this weird needle to thread of like, we need to honor and respect the places that people are bummed out, they're grieving, like the things that they did not get, that like we all care about really different things and want different things. And if we're the one in the body and we're having experience like that, being able to also say, no, I like, there's still so many things that I can work towards right now. Like having that ability to pivot, I think, and focus on those things too is
I love
super
that.
important.
Yeah, I love that. We'll put a link to that in the episode notes too, so that people can grab that resource from you as well if they're interested,
Sure.
because that's really cool. Okay, so can we talk a little bit about epidurals and options for managing pain during labor and delivery that you've seen?
Yes. So, I mean, I guess epidural pain, it kind of depends on how much you would want to hear. I think one thing that's really big about epidurals and pain management, and a lot of comes up a lot, and just nice for you guys to know, is there's the standard epidural that we all know about, right? And then there's this thing called the walking epidural, and people are always really curious about it.
What
Casey's
is
jaw is dropping
that?
right now, you guys.
A walking? I would have loved
Well,
that.
because it's not really that available, but you'll still
Oh,
hear about it. And so it totally depends on the facility. Where I worked, we did have a walking epidural available. And so it's essentially like it the process is the same for putting in the epidural and having the anesthesiologist come in and do that for you. But it's a different type of medication that they put in that space, and it still allows you to move, but to get some numbness, which
wow.
everyone's like, why are we not using these? They
Yeah.
typically weren't super effective, or they wore off like, this is just anecdotal, but I saw all the time, like within 45 minutes to an hour, they're like, it's not working. Like, I'm feeling everything. I want another dose. And then you're chasing it, but the second, third dose doesn't work. And so they just convert it over to the real thing. So there's a lot of anesthesiologists or facilities who are like, it just doesn't do
Mm,
that much. If someone wants that type of pain coverage, then really what they're wanting, I'm speaking like for them, is the full epidural, right? So that
mhm.
they don't feel anything. And the walking epidural could be funky because it's like, yes, in theory you can walk, that's its name, but you need someone with you. And what if your legs are too numb to walk? Then you're just staying in your bed anyway. So it got used or tried often, but I would say 99 times out of 100, it got converted over to I'm saying like the real thing
Yeah.
within like an hour or something like that. So
Wow.
just something for you guys to know, walking epidurals are a thing. You can totally ask about them and look into them and see if your facility offers them. If it's available to you, like, I think it's certainly something to try. In theory, I like the idea of if someone's feeling kind of ready to get an epidural, a walking epidural, if they continue to be pretty mobile, keeps you out of bed longer. Maybe you get another centimeter or two dilated because you're comfortable enough to keep moving. Like, that's all. That's
Mm,
always a good thing, right? And then the full epidural, I mean, everybody knows what that is and what it's supposed to do, right? Is that you're supposed to be pretty much fully numb from belly button down or whatever, and that then keeps you in bed. And then any labor nurse or doula or birth professional is going to say, keep moving while you're in bed, right?
yeah.
So you should have this kind of, not, I don't like to say full pain relief. We had a CRNA who used to say, if your pain's a 10 out of 10 right now, I want to get you to a 3 out of 10. And I love that he did that because he was really referring to the fact that a lot of epidurals, you still feel pressure.
Mhm.
And for some people, this expectation of, I want to feel nothing, so give me that epidural, that might not actually be like a smart or like a comprehensive expectation, because a lot of times you are still going to feel something, but it shouldn't be painful. And so I liked that he set people up that way for it. And then pain management in general, this could be like a whole podcast. But there's a lot of like options leading up to the epidural too. So I always just encourage people, even if you're saying, I want an epidural, that's definitely my goal. I'm good with it. I don't need to be, convinced otherwise. Learn the options leading up to that point so that if you're thinking, I want to keep moving, or this is valuable, or maybe your provider is saying, I really don't want you to get one yet. And y'all can have that conversation with them, because some providers will let you have it at 1 centimeter and some want you to wait until a certain point. Um, but it is really nice to know other options,
Mm,
because sometimes it is cool to try other things before you then do that. Because once you've chosen an epidural or you have an epidural, you're in bed for the duration. Um, and yeah, I mean,
yeah.
you could turn them off, I guess, but I've never seen someone turn one off and get back up. Like, that's
Yeah,
just not
yeah.
how it's going to
Yeah.
go. So,
Love it. Okay. Also, I just want to say this one thing in case anyone is pregnant for the first time and like thinking about potentially getting an epidural. Just know that there's usually like one anesthesiologist. And sometimes, like for me, I was like, okay, I'm done. I need it now. And they were like, well, he'll be here in an hour and a half. And it was like another hour and a half when I had already like mentally kind of made up my mind. That was hard. So like, if you feel like you're getting to the point, maybe just have that conversation. Like, would you want someone to have that conversation with you prior to be like, you know what, I'm starting to feel like I might want the epidural, you know, like, can we get a gauge on where the anesthesiologist is kind of thing? Or is that like a unique experience to me that he was just really busy?
Absolutely. I would want to know. And, you know, most nurses are going to be asking you that, whether you're being admitted for an induction or admitted in labor, you know, they're going to say, hey, are you going to want an epidural? And that's because there's things that have to happen before you can get an epidural
Yeah.
clinic, like that the nurse is doing as well. And so they would want to have all those ready too, right? And so you need an IV and you need a certain, typically they want you to have fluids running in your body a certain amount. You have to have blood work drawn and resulted because there's certain results in your blood work that indicate whether or not you can have an epidural. And don't panic. Like most people can have an epidural. It's about your platelets, but most people can have an epidural. And so, you know, the nurse is going to have those things ready. And a nurse is going to be pretty aware that you're probably getting close to a point where you might ask to, right? And so communicating with them is a great idea. So they can be immediately ready. I would say probably any nurse's goal, always it was mine, is the second they ask to be like, great, I'm ready, I'll call them right now. Like to be that ready for them. Your experience is not like specific to you. I would say that happens a lot. So it is really good to be aware of the fact that certainly if you walk in the door and you're 7 centimeters and you're like, get me an epidural right now, they will not be able to get you one within 10 minutes. Like understanding that those things I just mentioned have to happen, even if their anesthesiologist is at the door, like there's just certain things that have to happen before they could place that epidural for you. And so that goes back to this idea of knowing your other pain tools, right? And so let's say it is you, Casey, and you're waiting 90 minutes because they're in the middle of a C-section and there's only one available right now. Then you could maybe utilize like IV pain medications. So learn about those, right? If you're not 9 centimeters or 10 centimeters or nearly having the baby, it's a really good chance you could have IV pain medications. And maybe that'll keep you comfortable for 45 minutes if you're waiting and you're just not okay. Then you could try that, you know, or maybe the nitrous or something. And so I like, regardless of, again, that idea of I want epidural, I am going to that place. That's the road I'm on. You might want to utilize some other stuff because you have to wait, or the CRNA is busy, or things are just going so fast. Yeah, there's lots of different reasons that maybe you need some other tools in the toolkit, even when you totally want that.
So for this last piece, as we wrap this up, I would love for you to just talk a little bit about C-sections. So planned versus repeat versus emergency versus VBAC. I know this is probably a whole podcast in and of itself, but is there a simple breakdown for explaining really like when are the indications for someone who is potentially going in for a repeat C-section? Or let's start with this. How about an emergency C-section? Would they make that call? Is there really anything, is there other options, or are people really, do they need to understand that like that is happening and it's an emergency and we're going to roll with it, and then we have the option potentially for a VBAC afterwards?
Yeah. So the first thing I would say is a VBAC is going to be, just so for all of you guys listening, a VBAC would be like what you would do in a subsequent birth, right? And so if you've had a C-section for whatever reason, then your next baby, you could consider having a VBAC, which is vaginal birth after cesarean. And so if you were to need this C-section for whatever reason, let's say with your first baby, then in the back of your mind, not that you're really going to be thinking about it at that point, maybe you are, you could say, all right, like my next birth, I want to consider VBAC and pursuing that option. When it comes to like how quickly these decisions are made, or, you know, do you really have like a choice in the moment? I think it just depends on why the cesarean is being called. There's actually different types of cesarean births. There's planned, right? So you know it's going to happen and you go in and you check in, like, let's say you have placenta previa totally covering your cervix, right? You're going to have a cesarean. There is no other option for baby to be delivered safely. And so that's planned. And you go in and those kind of, I'm going to use the phrase like they go off like clockwork, right? And unless somebody jumps in front of you with an emergency C-section. And then there's emergent and then there's urgent. And an emergent one is typically going to be one that becomes necessary based on what's going on maybe in your labor, right? And so maybe you've been stalled at 8 centimeters for 10 hours, or maybe you've been ruptured. I'm just making stuff up. Not all of this would mean you have to have a cesarean. Maybe your waters have been broken and you have a fever and it looks like you have choreo and baby's not responding well, all this stuff. And it's like, you know, I think we need to deliver this baby via C-section. Now, those are often going to be called emergent. And what it means is this is what is best. This is, you know, and they're still talking to you. We're not running to the OR, but it becomes apparent that that's the way the babe needs to be born. And so typically, like, that's going to cut in front of any planned C-sections. They are going to, you know, roll you back often like within the hour, within the half hour, however quickly the team can get together. But it's not a sprint to the cesarean. And so often you can ask some questions, have some time to process. Like, no one's I'm going to say panic, I guess, but moving super quickly, but they are moving very efficiently because it's time to have baby and we're going to do it in a different way. And then the urgent one, or like crash, I'm sure some of you would be familiar with the term crash C-section. That is the true, like, unplugging cords. We are going right now. And sometimes that can be one where, you know, maybe birth partner can't be in the room. Maybe you have to be under general anesthesia. There's just kind of this spectrum, right? And there might be someone who says, I wasn't under general anesthesia, but we moved like really, really fast, right? And so that's kind of semantics. It doesn't matter. And you're going to process that the way that you experienced it too. But there is kind of the one most not significant, severe, or most emergency one would be that type where every once in a while we are sprinting to the OR and moving as fast as possible. And ideally someone's letting you know what's going on, but they're also going to be moving fast. And then there's this kind of tons of in-betweens between that planned and that scenario where something comes up and changes the process. And often you have a little more time to ask questions, take a breath, but also that's how you're going to meet baby.
Yeah. Okay. So to wrap this up, can you give us your number one tip for following your intuition and or you and your partner advocating for yourself? Like, what would be the number one tip that you would give every pregnant woman going into labor and delivery?
I think it's really important to be really comfortable with asking for time and space. And this can be prenatally, this can be in labor, this can be postpartum. I think that a lot of the power dynamics, particularly in, you know, if we're doing a traditional like prenatal appointments and having a baby in a hospital, they just set you up to feel like you guys don't have a time or space to decide what you want or even to think, right? Like, think about even the labor bed. You're literally laying down and everybody in the room is standing above you. And lots of providers are great and they're aware of this and they sit on the bed and they sit on a stool, right? Because that's just this thing about the way we're communicating with each other. It puts this inherent like power dynamic in place, whether or not the people in the room want it to be there. And so I like when people practice like asking for time and space, or almost this idea of, you know, prenatally, I always say, ask what's going to happen at the next appointment. So you walk in there and you're not going, oh, I didn't know the GBS screen was today. Tell me more. And you're almost like backpedaling for information. So practice that idea of being more prepared, asking for more information. And then when you are in labor, just the simple skill of saying like, okay, that sounds great. Or but I'd still, can I have 10 minutes to just chat with my doula and my birth partner or whatever? And recognizing that you're allowed to do that. I think a lot of times we agree with the plan of care, or we're comfortable with it. And it's not that I'm telling you just decline or not something like that because it's your right, but I just want people to feel like they got to actually decide or got to actually be there. And it gives the two of you also the chance to be in it together. Like, even if it's just, my husband's name's Kelvin, like Kelvin and I just going like, all right, Pitocin, we're good with this, right? Like, we know what it's about. Just having that ability for the two of us to say, and then, you know, the nurse calls your doc back and like, hey, they're ready to go. They're going to start the Pitocin or whatever. So I think that for you individually and then the two of you together, having that skill or that strength to just be comfortable to say, thanks so much for the information. I'd like some time and space for a minute just to talk and process and take a deep breath.
I love that. I love that. Okay. This was amazing, and I know will be so helpful for so many people. So can you just tell us one more time where people can find you, where they can find your resources? We'll link everything in the episode notes too. But you obviously have so much really helpful information to offer. So thank you for sharing all of it with us. And yeah, let us know where they can find you.
Yeah. So I'm the Labor Mama. I spell Mama MAMA on all the social platforms. My website's actually the same, labormama.com, where you can get, free resources and information on courses, classes, etc. too. I have a podcast as well called Lo and Behold, Casey's episode. I forget what number it is, so I'm not going to throw it out there, but it's up. It's out there if you want to hear us talk more about her work and what she does. And then I can share the link with you as well for this birth plan, birth priorities little packet. And we can
Amazing.
put that in the show notes for you guys too. And that's free as well. You can just snag that and kind of start thinking about priorities and stuff the way that I laid them out as well.
Sounds great. Thank you so much for being here. And we will see you guys next time on another episode of More Than Milestones.